Warm welcome, dear students. We have been learning about the complications of suppurative otitis media in the previous videos. In this video, let us look into the intracranial complications. We have already completed intratemporal ones and all the other extratemporal abscesses. Now let us look into intracranial complications. These are more serious and life-threatening also. Let us begin this list with extradural abscess. Where is an extradural abscess seen? It is outside the dura, as the name suggests. So it is collection of pus between the bone and the dura mater, and it occurs by direct extension, that is by direct bone erosion. So the basic definition is important. It is collection of pus between the bone and dura mater. It's usually found between the eroded inner cortex of the bone and the dura mater. This can occur as a complication of both acute otitis media as well as chronic otitis media. In acute otitis media, the bone is eroded by hyperemic decalcification, whereas in chronic otitis media, it is eroded because of cholesteatoma. As we already know by now, cholesteatoma releases various bioenzymes that can cause degradation of bone. It also activates osteoclasts and various other inflammatory mediators which altogether will finally erode the bone. And once the bone gets eroded, infection spreads. Apart from this pathway, there is another possibility by which extradural abscess occurs, that is from the veins. A sinus thrombophlebitis, which is another complication of otitis media, can lead to brain abscess further on. So we can further describe extradural abscesses based on their location. What are the common locations? Let us see. The common locations in which we find extradural abscesses, one is around the lateral sinus. Next, opposite to the middle cranial fossa. What is the landmark separating the middle cranial fossa and the middle ear? It is the tegmen plate. So once the tegmen plate gets destroyed, infection spreads into the middle cranial fossa. And you see the abscess opposite to middle cranial fossa. And anterior to the petrous apex also, you can see the abscess. And how does it go there? How does it spread into that area? By destroying the petrous pyramid. And finally, opposite to the posterior cranial fossa also we can see where it destroys the bone in the Trotman's triangle. When the bone in the Trotman's triangle is destroyed, infection spreads opposite to the posterior cranial fossa. So these are the common routes by which the infection spreads and the list of common locations. Now let us see what exactly is happening, the pathology. If it is an acute otitis media, I have already told you, the bone is destroyed by hyperemic decalcification. And if it is chronic type of otitis media, especially with cholesteatoma, the bone is destroyed by bioenzymatic activity. In both the cases, after the bone is destroyed and eroded, the pus comes to lie directly between the dura mater the pus comes to lie between the dura mater and the bone, that is in the epidural space. This is one route of spread of infection. The other method is by venous thrombophlebitis. If the infection spreads by venous thrombophlebitis, there is no destruction of the bone. No erosion of the bone remains intact. Although the infection is between the dura mater and the bone, there is no bone erosion. If at all, the spread of infection occurs by venous thrombophlebitis. Now let us look into the clinical features of extradural abscess. Now the clinical pattern depends upon the site of abscess and its duration and the rate of development. Now most of the times it's generally an incidental finding. When a cortical mastoidectomy or a modified radical mastoidectomy is done, we accidentally find the abscess, so it is asymptomatic. But if it is a chronically discharging ear, then we have to suspect extradural abscess if at all the following features are present. What are those features? Number one, if there is severe ear pain, that is steady throbbing and boring type. Severe ear pain. And what is the nature? It is throbbing, boring, and it is very severe, and it is constantly present. Second, ear discharge should be there. What type of discharge? It is profuse, creamy, and sometimes it is pulsatile. Please remember, pulsatility is a very important feature. Why does the discharge become pulsatile? When there is compression of the internal jugular vein, the degree of pulsation of the discharge will change. Then there are some constitutional features. Such as general malaise and fever. The fever is not a very high fever, it's a low grade fever. And finally, the last clinical feature that makes you suspect extradural abscess is a persistent headache. But please remember, this headache gets relieved upon discharge of pus. Whenever there is spontaneous abscess drainage on the side of otitis media, the headache gets relieved. So if any of these clinical features are present, please think about extradural abscess. Next, let us look into diagnosis. How do we diagnose an extradural abscess? Number one, a contrast enhanced CT scan is a good investigation, or a contrast enhanced MRI can also be done. You can see dural elevation. The dura mater is elevated. This is indicative of an extradural abscess. And what is the treatment? Antibiotics are given pre-op and post-op for a minimum period of 5 days, and the patient is closely observed for any further complications also, such as meningitis or brain abscess or sinus thrombosis, other intracranial complications. Apart from antibiotic therapy, the required procedure, surgery to be done is mastoidectomy. It could be cortical mastoidectomy, modified radical mastoidectomy, or a radical mastoidectomy, depending upon the severity and the location of disease process. An extradural abscess is evacuated. It is removed until the overlying bone becomes healthy and the healthy limits of bone and dura are both reached. Now sometimes, even if you cannot see the abscess, while performing the surgery of mastoidectomy, if there is a strong suspicion of abscess over the tegment tympani, we deliberately remove the tegment tympani and see if there is any abscess. And if at all there is abscess, that can be evacuated. So apart from antibiotic therapy, please understand that mastoidectomy is the surgery of choice. And then it is important that these patients are followed up and observed to see that they don't land into other complications. So this is all about extradural abscess. It's a pretty simple topic. I'll quickly revise this for you. First, it is the collection of pus between the bone and the dura mater. And the common locations are around the lateral sinus, opposite to middle cranial fossa, opposite to posterior cranial fossa, and anterior to the petrous apex. What is the pathology? The bone is eroded or it is via sinus thrombophlebitis. venous thrombophlebitis. What are the clinical features? Ear pain, persistent headache, ear discharge, and general features like malaise and low-grade fever. Ear discharge is pulsatile. And the diagnosis is by CCT or contrast enhanced MRI, and treatment is very simple: antibiotic therapy adequately plus mastoidectomy, and a follow-up for other complications is required. This is all about extradural abscess. Thank you very much.